Hello and a very warm welcome to this introduction to graded motor imagery. My name is Joanna Taylor. I am Director of NOI in Europe, and I'm joined this morning by my good friend and Principal NOI teacher, Tim Beams. Good morning, Tim.
Morning. Yeah.
Tim and I have been working together for a very long time. Now, every time I say this, it feels like it's getting longer. He's taught literally.
It is getting longer.
It is getting longer. I know. I know. God, the time just goes, doesn't it? Yeah. Tim taught literally hundreds of explain pain courses and graded motor imagery courses to thousands of people all over the world. Tim is himself an active clinician specializing in complex and persistent pain, and he's also a clinical mentor and coach for other therapists. Founder of Le Pub Scientifique and also a pain consultant for pelvic pain matters. He is also co-author of the Graded Motor Imagery Handbook with David Butler and Lorimer Moseley. So that's a pretty good place to start, really, Tim. Would you like to get started by telling us a bit about what graded motor imagery is? Please.
Yeah, sure. Thanks, Jo. And hello, everybody. And it's great to see people from so many different places. And just looking at some of, particularly the Australian places, we taught some of our first courses in Adelaide first of all, and then did a trip down the Great Ocean Road to Melbourne and then up to Sydney, and we we knew a bit about GMI, but God, things have changed since then, and that was 12 years ago, 13 years ago, and then and the book is now 10 years old, so it has been updated slightly, but yeah, it's ridiculous thinking about it. GMI, well, in the original conception, which really was Lorimer Moseley's work, was very much a brain-bound technique to help people who were experiencing pain problems that are typically really difficult to treat. So yeah, at a very, very simplistic level, the idea was that if you experience pain when you moved, could you do something pre-movement? And an idea was, could you imagine moving? And if you could imagine moving and there was less pain or there was no pain with that, perhaps that would be a good thing to start with. So, and then an idea really was then around the exposure of movement to that person. So gradually exposing that person to movement in a number of different ways. So graded cortical activation might be a way of thinking about GMI, graded motor imagery. But it's changed a lot, in my mind at least. It's changed a lot. What I think graded motor imagery is now is very, very different from what I thought it was then. And a lot of that has to do with the type of sort of philosophical model that I use to make sense of pain and the human being, and and we don't quite know where that fits then. So we're at this really interesting sort of juxtaposition where we think the old model that was used to first of all develop and then make sense of the results is probably not the right model, and it needs updating and changing. So yeah, GMI in a nutshell is graded brain exercises. It is a sequence of techniques where you start with one technique called left-right judgment tasks, which is where you look at a bunch of pictures of body parts and you guess whether you're seeing a left or a right body part. You then move on to the next sequence, which is motor imagery. So you imagine yourself doing some movement. And then the third task is a mirror therapy, or mirror visual feedback. So you watch the reflection of a body part moving in a mirror. So that's the sequence of GMI in its simplest form.
Yeah. Okay, thanks, Tim. I did just forgot to say at the beginning there, if you've got any questions that you want to ask, please drop them in the Q&A. It's one of the purposes of these sessions is that we actually get to answer your clinical questions live, or just questions, anything to do with what we're talking about. So what kind of patients would benefit most from this approach, Tim, in your experience?
Yeah, well, the people that GMI is typically associated with is complex regional pain syndrome. And the reason for that is that Lorimer wanted to choose a condition that was typically really tough for us to treat and for people to experience any success with. And I think perhaps rightly or wrongly, GMI is so strongly associated with CRPS, where there's been more trials exploring the effect of GMI than anything else, that we don't realize that it could be effective in other pain states or movement disorders, maybe elsewhere. So some of the other areas that people have explored using GMI are things like phantom limb pains, post-stroke pain. I've not seen many, I've only seen a couple, but brachial plexus avulsion injuries. To my mind, given what we now understand about GMI could be used in a number of different ways, though. So we could use the principles of GMI at a performance level. So we could do it not just for someone who's struggling with movement. So maybe they've got certain dystonias, or maybe they have dyspraxia, but it may be helpful for someone at a high level of sport to enhance their performance. And we certainly see, I was watching over the summer, there was a load of different sports going on. And one of them that I really thought was interesting was diving. The 10-meter diving board is so high up, isn't it? It's crazy high up.
Yeah.
And it was the European Championships, and they were diving off the 10-meter board outside, and they couldn't spot the top of the water very well. And what you notice them doing in the build up to the dive is they're doing this mental rehearsal. They are diving, they're doing the dive in their head. And you know, that just demonstrates how at elite level athletes are using components of GMI to enhance their performance.
So it's so interesting, isn't it? Do you feel like it's really just touching the surface of this? Yeah. And
it's like, you literally, I mean, obviously I've thought about it an awful lot. You could just take left-right judgment tasks, and we know so little about certain components of it. So the focus almost entirely has been on, let's test the performance of the affected body part. So we know quite a lot about what happens to the performance of someone looking at left-right judgment tasks when they're looking at their affected body part, but we don't know what happens if they're guessing for other parts of their body. So there are some really interesting, there's data lacking in areas that in clinic, what we've been able to do is we've been able to trial this, and we have some great evidence. I mean, it's anecdotal evidence, it's evidence from our practice of what happens when we incorporate this, and there's a lot more variability in performance of just taking left-right judgment tasks, for instance, of that task for someone in pain. So what we now see is GMI needs to be a lot more flexible. So whereas beforehand, a lot of people use Lorimer's original 6-week protocol, do 2 weeks of this, start using it in this particular way, and gradually build up, then move on to the next phase, park that phase, do that phase and gradually build that up, and then move on to the next phase. Actually, what we realize is it needs to be much more individually tailored, which for most people on this call, they'll be thinking, of course it does. Of course it does. I mean, that's just so ridiculous, isn't it? Of course, we should always have done that. But you can't necessarily easily at least design research to be that flexible. So
yeah,
there's a lot that you can do clinically, but it's still difficult to be able to understand and rationalize from a research perspective.
There's just a question here actually from Jill. Fantastic question, pretty much exactly to what you've just talked about, Tim, which is how long should patients stay within each stage? What are measurable signs patients are ready to move on to the next step? And how quickly, in your experience, do people see a benefit either functionally or with their pain within each step? And again, Jill says, I appreciate it's difficult to put a timeline on each, as each patient is different, which preempting exactly what you've just said. But do you have any thoughts on that, Tim? I mean, obviously it's difficult in a half-an-hour session today to, and you know, the 2-day course goes into all of this, but just any thoughts?
Yeah. Thank you, Jill. Sorry, God, where's it gone? There, it's gone. Yes, Jill, brilliant question. I mean, there's a few different parts to that question. So the first thing I would say is my experience hasn't been that pain changes significantly during, for instance, the practicing and rehearsal of left-right judgments. I think pain seems to have its own journey, and that doesn't necessarily have a strong relationship with how well they are performing these certain tasks. There might be a change in what I'm interested in. If I take my CRPS patients, I'm interested in flattening the curve. So I want to reduce the number of flare-ups and reduce the intensity of the flare-ups, and those sorts of changes are more typical of what I might see as someone practices and rehearses. When are people ready to move forward? Well, again, the research mostly stays true to Lorimer's protocol, either a 4-week or a 6-week protocol. My experience has been something totally different, and I have people who might keep rehearsing the left-right judgment tasks, but they're at work, they're functioning quite highly, but they might maintain a part of the GMI process because it's been so effective for them. I have someone with a trigeminal neuralgia actually who just springs to mind now, who carries a mirror with her to work. So she finds that if she uses her mirror, that it basically nips everything in the bud. So if she starts to experience the symptoms of trigeminal neuralgia coming on, then she can use the mirror, and that can reduce her symptoms straight away. So essentially she nullifies the symptoms. And then I'm just thinking about someone I'm seeing at the moment, and she's using GMI in hospital. She's an inpatient, and actually things have been too sensitive. So there are times when we need to take steps back as well. So there is a part of, I wouldn't call it trial and error, but a sort of knowing experimentation. So sometimes we need to sort of stay with a process and perhaps just be a bit more respectful with the symptoms. So maybe just spread things out, do a little bit less, and occasionally take a step backwards as well, in order for you to more comfortably and more successfully move forward. So my experience, Jill, is that we need to be a lot more flexible than the 2-week protocol. We're actually been designing for the last 2 or 3 years a more flexible protocol to research. So it might be in, who knows, maybe in 2 or 3 years' time, we might have seen that more flexible protocol. And what we were trying to do, it's not spoiling too much, but we're trying to do things like measure of consistency over time, things like how much concentration, how easy it might feel. So you're taking a number of different measures of how the task feels to someone. So if someone is starting to find that things are quite easy, they're stable results, then it's very, it's indicative of them needing to move forward, or at least needing to create a little more challenge for themselves.
Is that all? Is that covered in the course, Tim? Oh yeah,
a
lot more. Yeah, okay. It's difficult to sort of encompass it in half an hour that we have today, but yeah, we're just sort of touching the surface. So you just touched on an example there of a patient that you're working with recently. Can you share any other examples or go into that one in a little bit more detail?
No, I'm going to keep it all under wraps.
Okay, thanks, Tim.
No,
that's exactly what
no, of course. I mean, they're just the people that I'm popping up in my head. So I had a session with someone I've been treating. He's got pelvic pain. Now, obviously, there isn't an app to guess your left and right pelvic parts, your genitals. So you have to be a bit more flexible with that. So we can be more flexible, but it's about, we're sort of thinking out of the box now, aren't we? So for him, I was choosing to look at the back, the feet, and compare it with his hands as well. So yeah, it's a pain condition that we thought about a lot, pelvic pain in men and women. But the process of GMI needs to be radically different. So for instance, you're not going to be using the mirror in the same way. You're not creating a sort of reflection. So, typically the mirror would be here and we'd have, let's say, the hand there, and we'd be looking into the mirror and seeing the reflection of this hand, but it's as if you are seeing this hand. And you can't do that with facial pain and back pain and pelvic pain. So we can adapt GMI. A question might be, is that still GMI then? I think it's still using the principles of GMI, but it's adapting that process. So
it's really mega flexible then, and you're taking elements of it into all different scenarios. I didn't even realize you were doing that. Yeah,
I think for me, what GMI has done is that it's just given me like creativity. It's somewhere not everybody can go, but we can use it as a process of exclusion as well. So we can use it as part of a clinical reasoning process. But yeah, there's so many different places we can go with it. There's another question here which I think might be interesting. Cool.
I'll read it, shall I? So we had a comment from Karen. Maybe way out there, you could work with 3D VR to pretend them to move. And then Melissa's just said VR could be the fourth stage after the mirror. What do you think, Tim?
I think it's really interesting. So when we did a study with subacute stroke, and we were comparing data in VR then, and it was not great, but also VR technologies changed so much, and even things like the affordability of it. So let's say an immersive experience, which motor imagery and mirror therapy might give us, we could also replicate with a virtual reality. So whether it would fit as another distinct stage, or could it be a part of what the GMI process is, I don't know. But it certainly, I think, really, really fits well with one part of where we might look at GMI is how, when someone is in pain, it might affect sense of agency, so their ability to effect and know that they are effecting movement, their action in the world. So in essence, you would be able to give them back the sense that they are the owner of a body part and that they are the agent in their actions. So I think VR could be amazing. It could be very cool. The obvious thing that I imagine we would find is that for some people VR would be too much. So the immersive experience, the sort of felt sense of that experience could actually tip people the wrong way. And we find that with mirror therapy quite a lot. Yeah. So Melissa, I agree. Would it be a third stage, fourth stage? I don't know. Or could it be a part of just rehabilitation. I've never been wedded to the stages as well. I actually really dislike saying stage 1 is this, stage 2 is that, stage 3 is this. And I think, excuse me, I think we need to be a bit more flexible with sequencing as well.
Yeah, well, that's certainly what is coming out here, is that the boundaries around the stages are getting more blurred, aren't they, because of the flexibility that it's actually affording you in terms of being able to help different types of patients. So there's another question in the chat here about, for example, the pelvic pain patient. And it says, does GMI work as well in patients where they can't use the mirror boxes as effectively, pelvic pain, etc.? How, and this comes back to, I guess, your skill in the using the approach flexibly. You know, so what do you think about that, Tim? Do you find it as effective when you can't use the distinct three process?
You are using it totally differently. So for the pelvis, for instance, it might be giving them, it might be graded exposure to seeing and touching the pelvis and genitals and that, and you can, I mean, if you work with pelvic pain, think of the types of problems that someone has had as well. So often they might have experienced quite extensive trauma related to the pelvic region as well. So the mirror boxes can be used very differently. I say mirror, and the same thing with facial pain as well. And there's something interesting about facial pain, isn't there, and mirrors, because most of us do look in a mirror at some point in a day. But in pain, we find that can change, and people, they might have a disliking of themselves. They might not want to choose to spend time grooming and making themselves look, you know, good, pretty, whatever. And then there are other sides of it as well with facial pain, where we see people experience a shift in their ability to experience different mood states and shift through emotions, and even to express those emotional states. So facial pain and the use of mirror boxes, we can think of bringing in more emotional, I mean, if you want, somatic sides to that therapy. So the felt sense of what an emotion is and seeing it in action as well might be a really interesting thing to use with mirror box. Yeah,
thanks, Tim. We've got a few more questions, so we'll just go through the questions if that's okay with you.
Sure.
Sometimes we get more questions than others, and this is one of those sessions. So Birgit, sorry about the pronunciation. Is GMI effective for other sensory aberrations such as restless leg syndrome and not just pain?
It could be. But obviously there's a number of things that could influence restless legs. So yeah, it could be.
Yeah. So yeah, something that just, so do people learn to sort of adapt the process for themselves? Is that the idea of
that's where
the GMI education?
Yeah, I think we're knowledgeable. So for instance, the lady I'm seeing who's an inpatient at the moment is also a therapist. So she's come to me for guidance. I think it's really helpful to have some guidance and some support when you're making those decisions. Yeah, great. Thanks. Great questions, everybody. Thank you very much for that. There is some funky questions. Can I take a couple?
Go
Michael Nat, is the theory you now use to interpret effectiveness predictive processing? Well, it could be, yeah. So at one level, we could use predictive processing, and I think that's quite a nice model for me. It fits well. At a broader level, we could try and explain things using an embodied cognition model, and really predictive processing should be able to fit with that. Yes, that would be somewhere to go.
Michael goes on a little bit further down there. Any thoughts on integration of GMI with altered states of consciousness, i.e. ones where models are perhaps more easily manipulable have I said that right? For example, I see imperial, oh my goodness, I can't pronounce that term. Can you read that?
Psilocybin. Yeah. So there is. I mean, Laura's actually started a PhD on this, hasn't she? So I've got a couple of
Laura
friends who are working with psilocybin at the moment, and I think there's a pretty good reason to believe that psilocybin or psychedelics might enhance the plasticity, the brain plasticity, cortical plasticity, and something that we see in persistent pain states and some of the really tough pain states like CRPS and phantom limb pain, etc., is that perhaps we would benefit from that enhanced plasticity. So alongside the right type of medication, the right type of drug protocol, I think GMI should fit really nicely. Yeah. And the way that people are taking it is, I mean, at the moment, they're doing two different things. They're either going for it, aren't they? I had one patient the other day just say, like, he got hold of some magic mushrooms from his mate and he tried it out, and there's no sort of dosing behind it.
No.
And a sort of one-off whacking some mushrooms down your throat, I'm not sure is the best way to do it. But there will be, you know, what is the right dose to enhance the plasticity effects that will enhance the effects of GMI. I mean, that's really, really exciting to think about.
Yeah, it is. It's really exciting, isn't it? That all of this is really exciting, really exciting. Yeah. We've got one last question, which I think we can just fit in. We've got a minute to go. Anyway, so from Deb, thank you very much. Great question. Do you have any time to discuss your initial RX regime for an angry leg, CRPS, initial knee injury, surgery, then slipped on wet floor, minor ankle injury has caused onset with autonomic changes, heat, redness, foot swelling, and inability to touch the leg at all. Unable to WB, unable to get ankle DF.
Weight bearing.
Weight bearing. Sorry, I'm not a clinician.
And then
in case you hadn't already guessed.
And ankle dorsiflexion. There you go.
Thank you. Thanks, Tim. Okay, go.
Hello, Deb. I mean, you just sound like someone I should know. Yes, I actually, the way that and this is we don't have enough time to talk about it, obviously, but I would say the way that I would treat someone like this is with kindness and respect. And a typical way of treating something like that is with less kindness and less respect, is probably sort of rushing in a bit too much, in my experience. Trying to do things like desensitization exercises that I think can just ramp everything up. GMI tweaked for this person, whatever that might be, because it might be that even looking at images of their feet are too much. So it might be that we would need to work away from an area. I would say, given what you're seeing here, then things like how to introduce touch would be interesting as well. So you said here, inability to touch the leg at all. So CRPS sometimes manifests with whole hemispheric side, like the whole side of a body can exhibit changes in excitability. So we could do a number of different touch or sensory retraining techniques that would be aimed at reducing the excitability in their nervous system. But I would be employing that well away from the most angry area, as you were saying. So I mean, even it might be on the opposite leg, or that can be too much as well. So I would be doing a number of things that perhaps just give that sense of calming, and for this person, possibly what else could just give that sense of calming and a part of relaxation and some education and some support, and all of those things play a part as well in the initial understanding of how they're doing. But yeah, main thing, kindness and respect, and finding ways of just
Thanks, Tim. That's great. We've just gone 2 minutes over. So I'm just going to wrap up now. Thank you very much for joining us today. It's been a really, really good session. We've enjoyed it a lot. Really, really interactive. We love it when the audience are asking questions and we feel like we're actually connecting with you and addressing some of the issues, clinical challenges that you face. We've just scratched the surface here today, but if you want a deeper dive, an in-depth understanding of what GMI is, how to use it, the techniques, and how to use it with your patients, then Tim's got a course coming up at the end of November. Starts, I think, on the 30th of November. It's online. You can join from anywhere in the world. And after this webinar today, we're going to send you a discount code. So it'll just be valid for 48 hours. So if you're interested, get yourself booked on and you can do the deep dive with Tim. If you're want to remain in touch with us and find out about the next sessions that we're doing online, then I've dropped a link into chat. I'll just drop it in again. This is the link to the NOI group clinical discussions, which is this, and it's a Facebook group, and it's a way that we can keep in touch with you and you can keep in touch with us. You can ask your questions and you'll find out about these free sessions that are coming up. These sessions are designed to support you in your clinical work and to answer the questions and answer the challenges that you are experiencing out there. It's free, it's open to everybody. We love having people in there, so please do follow the link, click on the link and come and join us in the discussion group. Our next session, Tim, is going to be in 2 weeks' time, and we are doing, what are we doing?
The alert zone.
Yeah, the alert zone. That's going to be really good. So do watch out for that, guys, and come and join us to find out more about the alert zone, what it is, and why that's relevant in your clinical work. So thanks again. Great to see you. Thank you for all your fantastic questions. And hopefully we'll catch you again soon. Take care. Enjoy the rest of your day.
Bye-bye.